Aortic regurgitation. Causes of chronic aortic regurgitation. The causes are congenital leaflet abnormalities such as bicuspid or unicuspid valve, VSD large supracrystal VSD, acquired leaflet abnormalities such as calcification, senile, infective endocarditis, rheumatic heart disease, congenital aortic root abnormalities such as connective tissue disease, Marfan syndrome, Ehlers-Danlos syndrome. Acquired aortic root abnormalities in aortitis such as syphilitic aortitis, Takayasu arteritis. Aortic dissection. Autoimmune causes are SLE, ankylosing spondylitis, Ritter syndrome. Now, most common causes of aortic regurgitation, they are congenital bicuspid aortic valve, infective endocarditis, rheumatic heart disease, connective tissue disorders such as Marfan syndrome and aortic dissection. Now, what are the causes of acute aortic regurgitation? They are infective endocarditis, acute aortic dissection, blunt chest trauma, post bicuspid aortic valve, RSV, acute rheumatic fever, acute prosthetic valve dysfunction. Leaflet causes are traumatic blunt chest trauma, acute infective endocarditis, acute rheumatic fever, acute prosthetic valve dysfunction, post bicuspid aortic valve. Post balloon aortic valvotomy. Aortic root abnormalities are aortic dissection. Now, how different causes produces acute aortic regurgitation? Infective endocarditis. Infection may destroy or cause perforation of a leaflet. Vegetations may interfere with proper coaptation of the cusp. Bicuspid aortic valve. Incomplete closure and or prolapse of a bicuspid valve cause isolated aortic regurgitation or combined AS with AR. Rheumatic heart disease. Cusps become infiltrated with fibrous tissue and retract prevents cusp apposition during diastole. Associated fusion of the commissures may restrict the opening of valve, resulting in combined aortic stenosis with aortic regurgitation. In calcific aortic stenosis patients, AR present in 75% cases. Now, AR may be tolerated for many years. How? Pathophysiology are in aortic regurgitation, blood flow regurgitates into the LV during diastole is compensated by increasing total LV stroke volume, requiring LV dilation, and AR creates LV volume overload. Extra volume of blood is pumped into the aorta during systole. LV in aortic regurgitation remodels to accumulate both types of overload with increased chamber volume and increased wall thickness. In aortic regurgitation, LV mass usually is greatly increased, often higher than in isolated AS. Patient becomes symptomatic when increased wall thickness reduces LV compliance and also increased diastolic pressure leading to pulmonary congestion. Then symptoms develop. Why systolic function declines, that is ejection fraction falls in aortic regurgitation. LV systolic function is maintained by combination of chamber dilatation and hypertrophy of aortic regurgitation. As aortic regurgitation persists and increases in severity, wall thickening fails to keep pace with the hemodynamic load and end systolic wall stress rises. Or at this point, the afterload mismatch results in reduced systolic function, that is reduced ejection fraction. Now, what are the symptoms of aortic regurgitation? Patient may be asymptomatic. AR may be tolerated for many years. Symptoms develops most often in fourth or fifth decade of life. Principal manifestations are exertional dyspnea, orthopnea. PND develops gradually due to increased diastolic pressure from high diastolic volume of AR leading to pulmonary congestion. Chest pain or angina may be nocturnal with diaphoresis. Diastolic aortic runoff into LV lowers diastolic systemic pressure, reduced coronary perfusion. AR usually exhibit reduction of coronary reserve, especially during exercise. Associated coronary artery disease, involvement of coronary arteries and aorta in syphilis. Syncope. Diastolic aortic runoff into LV, lower diastolic systemic pressure, reduced cerebral blood flow. Palpitation and disagreeable thoracic pain due to tachycardia and premature ventricular complexes. Now, what is the examination findings of aortic regurgitation? Why collapsing pulse due to wide pulse pressure? Why collapsing pulse due to wide pulse pressure? Exam related to cardiovascular system, pulse, large volume, collapsing pulse, pulsus bisferiens, more recognized in brachial and femoral than carotids. Blood pressure, high systolic, low diastolic, wide pulse pressure. JBP may be normal. Differential diagnosis, severe aortic regurgitation, large PDA. So, what are the differential diagnoses of collapsing pulse? They are severe aortic regurgitation, large PDA, ruptured sinus of Valsalva, hyperdynamic circulation. Low diastolic pulse, low diastolic pressure means abnormally low. Korotkoff sounds often persist to 0 even though the intra-arterial pressure rarely falls below 30 mm mercury. Muffling sounds in phase 4 correlates with diastolic pressure. In heart failure, diastolic blood pressure may rise in presence of severe AR due to peripheral vasoconstriction. And peripheral signs of AR. Precordium examination reveals apical impulse displays laterally and inferiorly. It is diffuse and hyperdynamic. Features of pulmonary hypertension, left parasternal hip, palpable P2. Early diastolic murmur heard best along left sternal border in third and fourth intercostal space. Severity of murmur correlates better with duration rather than intensity. Mild AR murmur in early diastolic. In severe AR, murmur is hollow diastolic. Mild AR high pitched and blowing. In severe AR may have rough quality. Now, what are the peripheral signs of aortic regurgitation? The Masset sign, head bobbing, head nodding with each heartbeat. Becker sign, arterial pulsation in retinal arteries and pupil. Muller sign, systolic pulsation of uvula. Dancing carotid or Corrigan's sign, visible carotid pulsation. Waterhammer or Corrigan's pulse. Quincke's sign, capillary pulsation in nail bed. Locomotor brachyilis, visible pulsation in brachial artery. Palfrey's sign, pistol shoot sound on radial artery. Trope's sign, pistol shoot sound over femoral arteries in both systole and diastole. Drury's sign, systolic murmur over femoral artery when compressed proximally and diastolic murmur when compressed distally. Drury's sign. Hill sign, systolic pressure difference more than 60 mm mercury in popliteal artery than brachial artery. Lighthouse sign. De Masset sign, impact on carotids may cause the head to bob. Corrigan pulse, sharp carotid upstroke followed by rapid decline. Quincke's traction on the thumbnail may cause the nail to be plethoric in systole and blunt in diastole. How examine? Exerting gentle pressure on tip of fingernail or transmitting a light through patient's fingertips. Water hammer pulse or Corrigan pulse, abrupt distension and quick collapse, best appreciated in radial artery. These are the stages of MR. The stages are 4 stages. Stage 1 is at risk of AR. Stage 2 progressive AR. Stage 3 asymptomatic severe AR. Stage 4 reveals symptomatic severe AR. Now, natural history of chronic AR. Strong predictor of clinical outcome are LV size and LV systolic function. Without surgical treatment, death usually occurred within 2 years after onset of heart failure symptoms, within 4 years after development of angina. Patients with NYHA 3 or 4 symptoms, 4-year survival only 30%. Measurements of LV systolic volume and systolic function are most important indicators of clinical course in asymptomatic patients. To identify high risk patient, to identify future high risk patient, assessment of BNP and myocardial strain is important. Now, aortic regurgitation, definition of aortic regurgitation. Here, backflow of blood from aorta into LV at early diastole. Aortic regurgitation. Causes of aortic regurgitation are rheumatic fever, infective endocarditis, syphilis, ankylosing spondylitis, rheumatoid arthritis, ruptured sinus of Valsalva. Incidence of AR, male-female ratio is 3:2. Incidence of AR with rheumatic fever, subclinical rheumatic fever is 50%, confirmed rheumatic fever is 25%. Determination of the etiology of aortic regurgitation, history, example, history of rheumatic fever, infective endocarditis, ischemic heart disease, family history. Look for other valve lesion, example, combined valvular disease suggests rheumatic origin. Evidence of disease in other system for determination of etiology of AR, such as Marfan syndrome. There is aesthetic body habitus, long extremities, arachnodactylic finger, flat foot, high arch palate, subluxation of lens, Ehlers-Danlos syndrome, skin sweating, flushing and worm, yellow linear streaks. In syphilis, there may be Argyll-Robertson pupils. In osteogenesis imperfecta, there may be blue sclera. In eye, hemorrhage and exudates. X-ray in aortic regurgitation for determination of the etiology of AR. Aneurysmal dilatation of the aorta or calcification of ascending aorta indicates syphilitic origin of AR. Congenital AR is overshadowed by aortic or subaortic stenosis. Now, possible symptoms of AR. Asymptomatic for many years, only disturbance can appreciated by prominent neck pulsation and awareness of heartbeat on lying left side. Fatigue, dyspnea, orthopnea, PND, exertional chest pain, palpitation, neck pain, abdominal pain, neck discomfort, dizziness on standing, excessive sweating. Common symptoms of AR are dyspnea, orthopnea and PND, palpitation, exertional chest pain, easy fatigue. Minor symptoms of AR is flushing, sweating, palpitation. Atypical cardiac symptoms of AR, neck and abdominal discomfort or pain, postural dizziness, excessive sweating. Sudden death in AR versus AS. Sudden death is rare in aortic regurgitation. Sudden death is common in aortic stenosis. Syncope and dizziness in aortic regurgitation versus aortic stenosis. Syncope and dizziness are rare in aortic regurgitation. Syncope and dizziness are common in aortic stenosis. Anginal pain in AR. Next common symptom to dyspnea in AR, particularly common in AR from syphilis and in older patients having AR from any cause. Mechanism of angina in AR. The mechanisms are decreased diastolic perfusion of coronary arteries, associated coronary disease, involvement of aorta and coronary arteries in syphilis. Mechanism of dizziness in AR. It is secondary to disturbance in cerebral circulation with marked change in posture and rapid diastolic runoff. Mechanism of neck and abdominal discomfort in AR. It is due to stretching of carotid sheath and abdominal aorta. LVF versus AR versus prognosis. Vicious cycle takes place, so prognosis is not good. An increase of diastolic blood pressure, peripheral vasoconstriction, so obscured peripheral signs of AR. In LVF there is fall of cardiac output, so peripheral vasoconstriction instead of vasodilatation of AR, leading to increased workload of LV. This is in consequences causes increase in grade of AR, so aggravate heart failure. Impact of mental stress or vivid dream on sign symptom of AR. It causes an increase in systemic arterial pressure and an increase in peripheral resistance, so tends to aggravate incompetence but reduces cardiac output and leading to palpitation and shortness of breath. Symptoms in AR, its value. Presence of symptoms in AR is always an indication for thorough investigation. Pulse in aortic regurgitation. Waterhammer pulse, Corrigan pulse. Sometimes pulse is of Bispherians type. Double peak pulse in AR with AS. Rhythm usually regular unless there is associated mitral stenosis with atrial fibrillation. This diagram shows Waterhammer pulse, and this diagram shows dicrotic notch pulsus Bispherians. Bispherians pulse with two peaks in systole. The pulse is rarely appreciated in patients with severe aortic regurgitation. Blood pressure in aortic regurgitation. Systolic pressure is often abnormally high and the diastolic is low. In severe case, the systolic pressure may be 250 to 300 mm mercury. High pulse pressure. Wide pulse pressure gives rise to the typical collapsing pulse. When we will call wide pulse pressure, when pulse pressure is more than 50% of systolic blood pressure. JBP in aortic regurgitation, usually normal. Precordium in aortic regurgitation. Chest deformity, pectus excavatum in Marfan syndrome. Apex displayed outwards and downwards. Apex forceful but ill sustained. Visible pulsation in second right intercostal space due to dilated aorta. Auscultation in AR. First heart sound soft or normal. Second heart sound normal. In AR, actually first heart sound will be normal and second heart sound will be soft. Early diastolic murmur, left mid sternal edge, best heart with breath hold in expiration, patient leaning forward but in aortic area in syphilis. Ejection systolic murmur due to high stroke volume, usually at apex or aortic area. Austin Flint murmur at apex. Pan systolic murmur of MR due to LV dilatation. S4 ventricular gallop at apex. Normally S3 is found in aortic regurgitation. De Maset sign. Head movement with heartbeat, systolic motion on entire head, head bowing with each cardiac pulsation, molar sign, systolic and diastolic pulsation of uvula, eye sign, alternate change in size of pupil, retinal vessels dancing, Corrigan sign, vigorous arterial pulsation in neck, carotid pulsation, Quincke's pulse, capillary pulsation in nail bed, under surface of tongue and retina in ophthalmoscope. Corrigan's pulse, collapsing pulse in the periphery. Droges sign systolic and diastolic murmur over femoral artery. Trope sign pistol should sound. Ewart sign signs of consolidation of left lung base. What is Ewart sign? Signs of consolidation of left lung base. Gerhardt sign, pulsation of spleen. Gerhardt sign, pulsation of spleen. Hill sign, systolic pressure in leg 60 mm mercury more than brachial artery. Lighthouse sign, movement of column during systole and diastole. There is alternating flushing and belching of phase. Alternating flushing and belching of phase of periphery. Cause of rapid runoff and its impact in peripheral sign of aortic regurgitation. Due to increased flow into LV and into dilated peripheral artery, rapid run of blood from aorta into LV and reversely from LV to aorta is equally potent cause of peripheral sign of aortic regurgitation. Mechanism of collapsing pulse in AR. Collapsing pulse means rapid rise and rapid fall of pulse wave. Rapid upstroke of the peripheral pulse is due to large LV stroke volume. Rapid fall of the peripheral pulse is due to diastolic runoff into LV and dilated peripheral vessels. Best sites for palpating collapsing pulse are radial artery, that is radial pulse. Maneuver to elicit collapsing pulse. Place the palm of one hand on the anterior aspect of the patient forearm. The arm held vertically upright so that it will accentuate the backflow of blood during diastole. So, rapid rise and rapid fall of pulse will be easily elicited. To elicit aortic pulsation at the right second intercostal space. See from side of the patient's bed. Examiner's eye should be at chest level of patient. Pulsation in that area is due to aortic pulsation with or without aortic aneurysm. Now, differential diagnosis of collapsing pulse or wide pulse pressure or rapid run-offs in pulse. They are AR, large PDA, aortopulmonary window, rupture sinus of valsalva into RV, VSD with aortic regurgitation, systemic arteriovenous fistula, truncus arteriosus, pregnancy, anemia, thyrotoxicosis, beriberi. Now, mechanism of high systolic blood pressure in aortic regurgitation due to high stroke volume. Mechanism of low diastolic pressure in AR because of rapid run of aortic blood into the peripheral arterial bed and back into LV. Diastolic pressure is a constant pressure in aorta between systole. In aortic regurgitation due to diastolic leak, this constant pressure cannot maintain. Determination of severity of AR by blood pressure. Severe AR pulse pressure is severe here when pulse pressure is more than 50% of systolic blood pressure and when diastolic blood pressure is less than 40 mm mercury. So, when we will call severe AR by measuring blood pressure, when pulse pressure is more than 50% of systolic blood pressure and when diastolic blood pressure is less than 40 mm mercury, then we will call severe aortic regurgitation. Now, LV receiving blood both in MS and in AR, but one produces MDM and the other produces early diastolic murmur. Explain. MDM in MS because it does not start until LV pressure has fallen below the LA pressure, that is 0.1 second after starting of diastole. Early diastolic murmur in AR, here LV pressure immediately fall below that of aorta after end of systole. So, it produces early diastolic murmur. Importance of specific sites to elicit early diastolic murmur of AR by auscultation. Sites where early diastolic murmur best heard depends on the degree of dilatation of aorta. If the aorta dilated significantly, example in syphilis, then the murmur is best heard at right of the right side of the sternum. If the aorta is not much dilated, example in pneumatic fever, then early diastolic murmur is best heard at the left of the sternum. Now, early diastolic murmur of aortic regurgitation versus pulmonary regurgitation. Common confusion in MS with pulmonary hypertension. Pulmonary regurgitation is commonly found in pulmonary hypertension, so loud second heart sound should be present. Here, early diastolic murmur readily heard in inspiration. In pulmonary hypertension, there is left parasternal lift, but in air, there is no left parasternal lift. In pulmonary hypertension, there is prominent A wave in JBP, but not in case of AR, confirmed by echo. In case of AR, fluttering of AML found in AR. In case of PR, there is thick, flat IVS due to pulmonary hypertension. Austin Flint rumble, referred to as the Austin Flint rumble. This murmur is due to competing jets of blood entering the ventricle from the regurgitant aortic valve and from the left atrium. The murmur may have presystolic accentuation and may mimic the murmur of mitral stenosis due to regurgitant blood over AML. Due to regurgitant blood over AML. PR. In PR, palpable P2 left parasternal heave, loud P2 early diastolic murmur in left sternal area, increase on inspiration, JBP prominent A wave. Discussion on X-ray findings in AR. Diagnostic importance of calcification of ascending aorta in X-ray of AR. Calcification of ascending aorta indicates syphilis. Importance of calcified aortic valve in X-ray of aortic regurgitation. Axial calcification of ascending aorta is diagnostic of aortitis and pathognomonic of syphilitic lesion. Assessment of LV enlargement in X-ray of AR. In posterior anterior view, lateral wall of the heart extends below the diaphragm. In low view, posterior wall of heart overlies the dorsal spine. Prognostic correlation between preoperative heart size in X-ray and postoperative prognosis. Cardiothoracic ratio more than 0.64%, prognosis is poor. When cardiothoracic ratio is more than 0.64%, then prognosis is poor. Now, symptoms of aortic regurgitation. What are the symptoms? The symptoms are easy fatigue, palpitation, dyspnea, orthopnea, PND, exertional chest pain. Signs of aortic regurgitation: pulse normal rate or tachycardia, high volume collapsing pulse, blood pressure high systolic, low diastolic, wide pulse pressure. Precordium, apex displaced downwards, outwards and downwards, apex forceful but it's sustained. Early diastolic murmur, left mid-sternal edge, best heard with breath held in expiration. Patient leaning forward but in aortic area in syphilis. Differential diagnosis of aortic regurgitation are aortic regurgitation and pulmonary regurgitation. Treatment of MR. Treatment of AR, medical treatment, surgical treatment. Investigation of aortic regurgitation, they are ECG, X-ray, echo, cardiac catheterization. What are the ECG findings in aortic regurgitation? They are LVH in chronic aortic regurgitation, STT elevation due to volume overload. In acute AR, there is no specific change or there may be changes of AMI. In 10% of AR, there is LBBB or complete heart block, even right bundle branch block present. The ECG shows LV diastolic overload in AR. The ECG shows LV diastolic overload in AR. X-ray findings in AR: cardiomegaly, LV type apex, dilated aorta. Chest radiograph demonstrates enlargement of the left ventricle with an aortic configuration, reflects adaptive dilatation seen in aortic regurgitation. Now, Echo finding. Now dimensions discussion on echo findings in aortic regurgitation. Echo findings in aortic regurgitation. 2D echo findings in AR. In parasternal long axis view, thickened aortic cusp in rheumatic origin, diastolic prolapse of aortic cups into LV, vegetation within cups if infective endocarditis, aorta dilated, LV dilated. In this 2D echo in AR, diastolic prolapse of aortic valve. Importance of 2D echo in aortic regurgitation can determine severity of diastolic prolapse of aortic cusp. M-mode findings in mitral valve in AR. M-mode findings in mitral valve in AR. Thickened anterior AML due to chronic irritation. Early diastolic closure of AML. Early diastolic closure of AML. Premature closure of mitral leaflets. Fluttering of AML. Fluttering of AML. Fluttering of AML. Fluttering of AML in aortic regurgitation. Fluttering of AML. Now, in 2D echo, mitral valve changes found in aortic regurgitation. Inadequate mitral opening reduces diastolic excursion of AML, that is diastolic fluttering by regurgitant jet from aorta at early diastole. Importance of Doppler echo in AR. It is sensitive for diagnosis or presence of AR. Sometimes it is used to assess the severity of AR. Doppler echo can demonstrate the presence of aortic regurgitation. Now, assess the severity of AR by Doppler echo with pressure half time. Continuous wave tracking taken from the apical 5-chamber view, illustrating the measurement of pressure half time in aortic regurgitation. Here the Bmax is 479 cm per second and the slope of the Doppler tracing is 310 cm per second. Pressure half time is calculated from the slope using an algorithm by the computer of the echocardiograph. Here the pressure half time is 453 millisecond. Pressure half time below 250 millisecond would suggest severe aortic regurgitation. Systemic vascular resistance and aortic and left ventricular compliance can also influence the pressure half time other than the severity of aortic regurgitation. Pressure half time in aortic regurgitation. Pressure half time in aortic Vmax, V minimum, pulse wave Doppler of aortic valve. Mild AR pressure half time more than 400 millisecond. Moderate AR pressure half time 250 millisecond more than severe AR pressure half time less than 250 millisecond. Now, assessment of severity of AR by Doppler echo with base study. The broader base of regurgitant jet, the greater the severity of lesion. Increased density of spatial tracing, increased severity of lesion. Now, assessment severity of AR by color Doppler echo. Good surgical indication in echo. LV IDD, when LV IDD in systole less than 55 millimeter, when LV IDD in systole less than 55 millimeter, if it is above 55 millimeter, then the prognosis is bad. When ejection fraction is more than 45% and cardiac index more than 2.5 liter per minute per meter square have been reported with higher operative survival with values below this level. Now, prophylaxis discussion on medical treatment of AR. Discussion on medical treatment of AR. Prophylaxis in AR. Prophylaxis for rheumatic fever if it is suggestive of etiology. Prophylaxis for infective endocarditis. Treatment of heart failure in AR. If heart failure, treat with rest, salt restriction, diuretics and digitalis. There is controversy about the use of vasodilator in CCF due to AR. Valve replacement should consider before development of symptoms. Peripheral vasodilation in AR. Wide pulse pressure stimulate the aortic and carotid vasoreceptor, so there is reflex vasodilatation. In vasodilatation, example in exercise or AC inhibitors, LV stroke volume become normal, so behave a normal hemodynamic. Peripheral vasoconstriction or increase peripheral resistance in AR. In peripheral vasoconstriction, example mental stress and exposure to cold cause vasoconstriction, so increase return of into LV. Simultaneously, cardiac output reduces, so reduction of grading of AR. Aortic regurgitation versus vasodilators. Vasodilators will decrease the preload and afterload, which does not have any benefit on heart of AR patients. So better avoid vasodilator in congestive cardiac failure from AR. Treatment depends on symptoms, severity assessment by echo, pressure, presence of any complications. Medical treatment includes if symptoms NYJ 1 to 2 in echo, AR, when medical treatment will given. If symptoms NYJ 1 to 2 in echo, AR grade 1 to 2, no complications. Discussion on surgical treatment in aortic regurgitation. Asymptomatic severe AR কি করব? Valve replacement is advisable in AR before development of symptoms. How do you decide for this surgery? In chronic AR, selection of the optimum time for valve replacement has been an important clinical issue. Surgery should be proposed ideally before symptoms of congestive cardiac failure or before refractory dilatation of the ventricles has developed. For this, an echocardiographic evaluation is informative and can be a guide for decision of surgery before development of symptoms. Example, 2D echocardiography. If LVIDS is exceeded over 55 mm, then surgery can be contemplated even if symptom is absent. To avoid advancement in AR, some periodic follow-up is taken in the following order. If LVIDS less than 50 mm, yearly follow-up is indicated. If LVIDS 50 to 54, then echo follow-up 6 monthly. Doppler estimation may add to qualitative estimate of regurgitation. Answer flowchart asymptomatic. Indications for surgery in aortic regurgitation. All symptomatic patients provided good LV function. AR with infective endocarditis, asymptomatic AR. Blood pressure, systolic 250 mm mercury, diastolic 40 mm mercury. LVIDS more than 55 mm. Normal LVIDS is 25 to 40 mm. ECG LVH more than 55 mm, that is V1 in S and V6 in R is equal to more than 55 mm. ST depression T inversion, grade 3 and 4 AR, angiographic grading or echo grading. Increasing enlargement of heart size in serial chest X-ray, example 2 cm per year or 2 mm per month. Acute AR due to infective endocarditis and aortic dissection. In Marfan syndrome, prophylactic resection should be considered when aortic root diameter is more than 55 mm. Indication of emergency surgery after AR by infective endocarditis. Acute AR from infective endocarditis with heart failure. Valve replacement under intensive antibiotic cover. Indication of emergency surgery in aortic regurgitation. They are acute AR from infective endocarditis, acute AR from acute dissection of ascending aorta, acute AR from tearing of aortic cusp. Grade 2 AR surgery is indicated. Explain. This grade 2 AR is associated with significant MR. What might the problem if surgery is delayed? If surgery is delayed, example heart failure, then result of operation is poor. Because dilated hypertrophy often fibrosed heart does not recover to normal. Precautions to be taken before surgery. Ventricular function should be stabilized, arrhythmias controlled, electrolyte abnormalities should be corrected, elective dental repair and other minor surgical procedures should be performed prior cardiac surgery. Cardiac status reverted after surgery in AR. Diminution of heart size but not normal. Symptoms relief but medical treatment may still require. Anchoring and a suturing of prosthetic valve in AS versus AR. So, anchoring and suturing of prosthetic valve in aortic stenosis versus aortic regurgitation. In aortic stenosis, there is fibrosis and calcific ring on it. Easily can anchoring suture. In AR, no such ring. Aortic valve, floppy valve leaflets, aortic valve repair surgery, aortic valve repair surgery. Results after surgery less favorable than aortic stenosis, largely due to CCF. In aortic stenosis, there is fibrous and calcific ring or aortic valve cavity can anchor suture. In AR, no such ring. Mention aortic biological heart valve. Made from tissue of cows, pigs, horses and humans. The tissue is properly treated in special chemical processes to reduce the risk of infection and rejection. Medical problem after valve replacement. Recurrent CCF due either to irreversible factors that were present before valve surgery or to myocardial disturbance related cardiopulmonary bypass. Prosthetic valve related infective endocarditis causing high incidence of reoperation or increase of death. Patient will require intensive prophylaxis during periods of possible bacteremia. Mechanical valve will require indefinite anticoagulation. Chance of thrombosis even with anticoagulants. Now, determination of severity of aortic regurgitation. Determination of severity of aortic regurgitation by clinical image findings, pulse, pressure and LV size. The severity of AR can be judged to a large extent from pulse pressure and size of LV, such as if pulse pressure more than 50% of systolic BP, then AR is severe. Similarly, there will shifted forceful apex beat blood pressure. If diastolic blood pressure is less than 40 mm mercury, then AR is severe. If systolic blood pressure more than 22 mm mercury, then AR is severe. Austin Flint murmur represents severe AR. Presence of S3 represents severe AR. Length of early diastolic murmur. Severe the AR prolongs the murmur. Determination of severity of AR by echo. In echo, diastolic fluttering of AML and early closure of mitral valve in diastole has been used as an indication of severity of AR. Doppler outline extents of the regurgitant flow into LV. So, the broader the base of regurgitant jet, the greater the severity of AR. Diastolic blood pressure versus systolic blood pressure in determining the severity of AR. Diastolic blood pressure is more important than systolic blood pressure. Murmur versus severity of AR and LV compliance. Early diastolic murmur of AR persists until backward flow of blood from aorta into LV at early diastole. So, the length of the early diastolic murmur depends on the severity of AR and compliance of LV. Severity of AR, large volume collapsing pulse, wide pulse pressure, Hill sign and pulse pressure, systolic blood pressure more than 220 mm mercury, diastolic blood pressure less than 40 mm mercury, presence of third heart sound, length of early diastolic murmur, that is hollow diastolic. Now, determination of dominant lesion in AR, AS, ARS. Determination of dominant lesion in case of combined aortic stenosis and aortic regurgitation. Determination of dominant lesion on clinical ground. Character of the pulse and pulse pressure are of great value. Collapsing pulse incompatible with severe stenosis. Small pulse makes major regurgitation unlikely. Pulse pressure more than 50 mm mercury of systolic blood pressure, then AR is dominant. Less than 50% of systolic blood pressure, then AS dominant. Determination of dominant lesion by investigation, such as in echo diastolic fluttering of AML and early closure of mitral valve in diastole, has been used as an indication of severity of AR. Doppler outline extents of the regurgitant flow into LV, so the broader the base of the regurgitant jet, the greater the severity of AR. Importance of murmur in determining dominant lesion. Murmur is not informative because loud aortic systolic murmur may also found in dominant AR. Similarly, intensity of early diastolic murmur is an unreliable guide for dominant AR. So the difference between aortic stenosis and aortic regurgitation. And aortic stenosis, the pulse will be small volume, slow rising, late peaking pulse. In AR, it is large volume, collapsing in nature. In AS, there may be no peripheral sign. In AR, peripheral sign may be present. In AS, narrow pulse pressure. In AR, wide pulse pressure. In aortic stenosis, systolic thrill. In aortic regurgitation, there may be diastolic thrill. In aortic stenosis, apex beat not shifted, forceful, well sustained. In aortic regurgitation, apex beat will be shifted, forceful, ill sustained. In AS, precordium is silent. In AR, precordium is hyperdynamic. In AS, presence of fourth heart sound. In AR, presence of third heart sound. In AS, there is ejection systolic murmur. In AR, there is early diastolic murmur. So, discussion on catheter study on AR. Aim cardiac catheter in aortic regurgitation. Doppler echocardiography in cardiac catheterization can be with the following aims: to confirm the diagnosis, to estimate severity of aortic regurgitation, associated abnormalities, LV function determination, coronary anatomy by coronary angiogram. Findings: dilated LV, dilated aortic root, aortic regurgitation. This is the root aortography in aortic regurgitation. Importance of catheterization for diagnosis of AR. Seldom required for AR diagnosis because AR rarely can diagnose clinically and by non-invasive method. Mostly required for associated coronary artery disease or other lesions or for grading. Indications of catheter in AR: severe and acute AR when valve replacement contemplated in chronic AR. Pressure study in AR. In early case without failure, there is normal LV pressure. In late case, there is high LV and diastolic pressure in LVF. In acute AR, reverse mitral gradient develops because LV pressure rises rapidly during diastole. Aortic pulse pressure is usually less than that of periphery. Now, what is the difference between early ejection systolic murmur and pansystolic murmur? Ejection systolic murmur harsh in quality, pansystole soft, smooth. Stop before second heart sound, merges with second heart sound. Now, management of aortic regurgitation. Asymptomatic patient, the general management are mild to moderate AR, normal or minimally increased cardiac size, no therapy, follow-up 12 to 24 monthly. Chronic severe AR, normal LV function, follow-up 6 monthly by clinical serial echo, LV size, ejection fraction, CMR, aortic size. Aerobic fear of exercise when LV systolic function is normal. Aerobic function of exercise. Blood pressure control, especially diastolic hypertension, should be treated if present by calcium channel blocker, ACE inhibitor, beta blocker with cautions and nifedipine. AF with bradyarrhythmia should be performed. No need of prophylaxis of infective endocarditis. Prophylaxis of rheumatic fever if cause is rheumatic. Drug treatment. No specific therapy to prevent disease process. Patients with Marfan syndrome, beta blocker and losartan may slow aortic root dilatation, reduce risk of aortic complications, should considered before and after surgery. Regarding pregnancy with Marfan syndrome and aortic diameter more than 45 mm, strongly discouraged from becoming pregnant. In bicuspid valve, counseling against pregnancy if aortic diameter more than 50 mm. Symptomatic patients, aortic valve replacement is the treatment of choice. Chronic medical therapy who refuse surgery, inoperable due to comorbidities. Aggressive heart failure regimen with ACE inhibitor, digoxin, diuretic, beta blocker, salt restriction. Candidate for surgery but severe decompensated LV dysfunction. Vasodilator therapy to stabilize patient. Algorithm: aortic regurgitation, severe or progressive. If severe, symptomatic, then aortic valve replacement. If severe but asymptomatic, if LV ejection fraction less than 50%, aortic valve replacement. Other cardiac surgery, if other cardiac surgery is needed, aortic valve replacement. If LV ejection fraction more than 50%, but LV and systolic diameter more than 50 mm, AVR class 2A recommendation. If LV ejection fraction 50%, LV and diastolic diameter more than 65 mm, AVR class 2B recommendation. If LV ejection fraction more than 50%, LV and systolic diameter less than 50, LV and diastolic diameter less than 65, periodic follow-up, periodic monitoring. In aortic regurgitation which is progressive, other cardiac surgery needed, AVR class 2A recommendation. Now, what are the indication of reimplantation or remodeling with aortic annuloplasty of aortic sinus repair? Indication of aortic sinus repair. Indication of aortic sinus repair. This is Bentall procedure, that is reimplantation or remodeling with aortic annuloplasty or replacement of ascending aorta. In cases of bicuspid aortic valve, with any degree of regurgitation, aortic sinus or ascending aorta diameter more than 55 mm, class 1 recommendation. Risk factors for aortic dissection, family history of aortic dissection, diameter more than increasing diameter more than 0.5 cm per year, diameter more than 50 mm, class 2A recommendation. Patient with indication of AVR, diameter more than 45 mm. Marfan syndrome with any degree of regurgitation, aortic sinus, ascending aorta diameter more than 50 mm. Risk factor for aortic dissection with diameter more than 45 mm. More than 55 mm for all other patients having aortic root dilatation. Aortic regurgitation, severe AR, stages C and D, vena contracta more than 6 mm, hollow diastolic aortic flow reversal, R volume more than 60 ml, effective regurgitation, or if it is 0.3 cm square, IVR. Symptomatic, asymptomatic. If symptomatic, AVR. If asymptomatic, LV ejection fraction less than 50%, AVR. If other cardiac surgery needed, then AVR. If LV ejection fraction more than 50%, LV and systolic diameter more than 50 mm, then AVR class 2A recommendation. If LV ejection fraction more than 50%, LV and diastolic diameter more than 65 mm, low surgical risk, AVR class 2B recommendation. If LV ejection fraction more than 50, LV and systolic diameter less than 50, LV and diastolic diameter less than 65, periodic monitoring. Progressive AR, vena contracta, progressive AR, other cardiac surgery if needed, AVR, class 2A recommendation. Other cardiac surgery is not indicated, periodic monitoring. Now, management of acute AR. Immediate Immediate aortic valve replacement. Acute volume overload leads to life-threatening hypotension and pulmonary edema. Acute volume overload leads to life-threatening hypotension and pulmonary edema. While patient being prepared for surgery, treatment with IV inotropes, dopamine, dobutamine, and or vasodilators, nitroprusside. In AR, in intra-aortic balloon pump and beta blockers are contraindicated. Acute AR secondary to infective endocarditis, hemodynamically stable. Deferred aortic valve replacement to allow 5 to 7 days of intensive antibiotic therapy. Now, surgery for aortic stenosis. Valve replacement in the surgery is the surgery in young patient through commissurotomy and calcium debridement can be tried, but ultimately require valve replacement. If there is concomitant coronary artery disease, then bypass should be done. Indication of surgery in aortic stenosis: symptomatic aortic stenosis such as angina, syncope, dyspnea. Asymptomatic aortic stenosis such as severe AS with infective endocarditis. How can you determine the severity of AS for surgery? Severity of AS can be determined by ECG, LVH with strain, in X-ray cardiomegaly with sign of pulmonary hypertension, in echo valvaria less than 0.8 cm square, acute aortic cusp separation less than 8 mm, transvalvular gradient more than 70 mm mercury. Early hospital complication after aortic valve replacement. Low output syndrome. It is characterized by hyperkinetic heart with hypotension, oliguria, impaired mental functions. Aortic insufficiency AMI due to cannulation of LCA or embolic calcification. Aortic valve block, so temporarily pacing is mandatory before operation. Cardiac tamponade due to bleeding. Late complications of aortic valve replacement: persistent LV dysfunction, MI due to perforation of aortic intima, thromboembolism, infective endocarditis, paravalvular leakage with AR, post-cardiotomy syndrome, hemolytic anemia, post-perfusion syndrome, fever, joint pain. Treatment: সহজ কথায় counseling of patient, avoid heavy exercise, treatment of comorbidities such as hypertension with ACE inhibitor ARB, coronary artery disease by beta blocker, dyslipidemia by statin, treatment of heart failure if present, diuretics cautiously. Definitive treatment interventions: balloon aortic valvotomy, TAVI aortic valve replacement. Now, bicuspid aortic valve. Congenital bicuspid aortic valve is second most common congenital heart disease. 1 to 2% of population. Autosomal dominant. Mutation in NOTCH1 gene. Male more than female. Association: 10% bicuspid aortic valve has coarctation of aorta. 50% coarctation of aorta has bicuspid aortic valve. Turner syndrome, Shown syndrome, mitral valve prolapse. Pathophysiology: 70 to 80% case fusion of RCC and LCC associated with ascending aortic dilatation. Increased aortic dissection risk 5 to 9 times. 20 to 30% case fusion of RCC with non-NCC. Now, clinical feature of bicuspid aortic valve. At 20 to 40 years of age may come as aortic regurgitation due to turbulent flow and leaflet stress. At 5th to 6th decade, aortic stenosis, echo, systolic leaflet opening with only two commissure M mode, eccentric closure line. Follow up with echo, MRI, CT scan to see for surgical intervention. Acute more than 4 cm with bicuspid aortic valve each yearly. Aorta more than 4 cm, aorta more than 40 mm, aorta more than 40 mm with bicuspid aortic valve each yearly. Aorta more than 50 mm or more than 0.5 cm per year increasing. Surgery design with valve surgery. Positive family history. If valve surgery needed, then aortic replacement done if more than 45 millimeter. Beta blocker if ascending aorta dilated. Beta blocker if ascending aorta dilated. Beta blocker if ascending aorta dilated. Risk factors for cardiac. Risk factor for cardiac age more than 30 years. Moderately severe AR, moderately severe AS. Surgery, symptomatic bicuspid aortic valve. In the absence of aortic valve disease, aortic root replacement is recommended if aortic diameter dimension is more than 55 millimeter. Thank you.